Dear Pure Urology viewers, good evening one and all. Today topic is related to the one of the minimally invasive treatments for BPH who are symptomatic when they are not fit for anesthesia. One of the such topic is Urolift. Today's speaker is Dr. Rohit Joshi. Most of the Indians know him. He is a young dynamic urologist from Ahmedabad, and he is consultant urologist and chairman Aparna Super Specialty Hospital, Ahmedabad, honorary treasurer of Ahmedabad Urology Association, honorary treasurer of West Zone chapter of Urology Society of India, founder council member of Youth Wing of Urology Society of India, his innovative thought, member USA Guideline Committee on BPH, special interest on endourology and uro-oncology, has conducted several live operative workshops and has been regular faculty in various national and international conferences. Anterior urethral diverticulum in ESRD patient is a case report in IJU. Vaginal metastasis from renal cell carcinoma is also another case report. Ureterochelicostomy, a salvage procedure, is published in IJU. The Urology Society of India guidelines on management of benign prostatic hyperplasia, he is one of the key person in Indian Journal of Urology on these guidelines. With this introduction, Rahul is my close friend. I witnessed in Safdarjung Hospital 2 times. Last time I was closely observing. He will illustrate in a normal language so that people can understand how it can be done, this thing, and what are the indications, how it is effective, everything he will speak. Honestly, we are in the learning stage. This is a new thing in India. So hope it will be very, very useful for the youngsters, both theory point of view, as well as for the practitioners, which patients to be selected. Rahul, thank you once again for accepting the invitation. Over to you.
Thank you, Chandra. With you and Mallikarjun sitting in Hyderabad, I don't even dare to dream to be settled down in Ahmedabad. I'm doing well in Ahmedabad. Thank you so much. Okay, so thank you so much for this kind invitation as well as this, introduction. I'm really honored and it's really a proud privilege for myself to be once again coming to this pure platform, which is really a kind of learning initiative. And I really appreciate this initiative from Chandra. And let's keep it rolling for long and increase its reach. As far as this Eurolift is concerned, this being a new technology, Chandra, it has been recently, not very recently, it has been almost 11 months that it has been introduced in India. I think it's high time that we all should get into the nuances of basics of this Eurolift. What is this Eurolift? With which patients we can offer this, and then we can gradually, adopt it in selected group of patients. So, with your kind permission, shall I share my slides and start my presentation?
Sure. Yeah, please.
Yeah. So, can we see my slides?
It's visible and clear.
Thank you. So this is regarding this Eurolift, a new frontier for BPH. Chandra and my friendship go a long way, and we have been thick and thin as friends for long. So I really, once again, cherish our friendship. We have been gathered in very social events and very academic events, and we have been together in several live operative workshops. So I keep on learning from him, and I wish, and I think so, same thing happens mutually. There is a lot to learn from each other and grow as a urologist and as a person. So I'll keep meeting you and keep growing myself as a urologist and person, Chandra. Let me first have a disclaimer that, my friends, I do believe that TURP is the gold standard treatment option for BPH patient. Nobody can take that away from TURP. So there is no debate over here. Subsequently, I also believe that HOLEP has been a size independent gold standard in last 2 decades, which has come big way for large gland BPH patients. I personally have an experience of more than, say, about 2,000 HOLEPs for last decade and 2 more years. I still end up doing 15 to 20 enucleations a month. But this gold standard remains, whether we talk about TURP or HOLEP, it remains true only if we considered urinary component as the BPH. But let us remind ourselves, BPH has many more components other than this LUTs. And currently, in all the fraternity, the most relevant thing is quality of life. Even in cancer patients, initially we used to be very radical. We used to remove every organ and surrounding organs. But now the focus is changed into giving the maximum and the best quality of life. So why not in such a benign condition? So I personally think we all need to train our minds to broaden our perspectives about BPH and its impact in elderly men. And when we do so, we can see that there is a space for MISTs. Now, this MIST is minimally invasive surgical treatment options for BPH. And this space is as big as the space in this slide. Nowadays, in my practice, out of those 20 prospective HoLEP patients, I still figure out one or two that can qualify for urolift. So it's all about our mindset as a urologist. So there can be two kinds of minimally invasive surgical therapeutic options for BPH. One category is tissue ablating, which can be in form of vaporization using various energy sources, aquablation. The resume is coming in a big way, or it can be histotripsy. While it can be tissue sparing, wherein we can have urolift, itin, and intraprostatic injections. But for the sake of today's presentation, I'll confine myself only to talk about the urolift. Now, if you ask me in a one sentence, if I need to define what urolift is, I can tell you this is a mechanical solution for a mechanical problem, which is a most logical one. I have divided the whole talk into these 12 different fragments. We will attend all these 12 different segments one by one. And to know a procedure, one needs to understand the history and the sanctions. So let me tell you, first time it was done in 2009 by Wu, and he published the first series of 64 men with BPH in Australia. After that series, it got approved by TGA in Australia in 2010. US FDA approved it in 2013. In UK, NICE sanctioned it for treatment of LUTS in 2014. And subsequently, to promote its widespread adoption, it was incorporated in ITT. This ITT is innovative therapeutic treatments. And after it was adopted as an ITT in 2017 by NHS, lot many patients and lot many cases were done in UK. In India, it was first introduced in 2022 November because it got the approval. And we are close to 11 months of it being introduced in India. And Pan India, we have now crossed 100 patients. And in my personal capacity, we're touching 20 a couple of days. So this is all about the history. The concept, we all know that mechanical problem in prostatic hypertrophy leads to the urinary kind of, blockage. And the concept in Urolift is different than what concept we have in TURP. So we need to create a very good channel, and that too in the anterior channel, anterior part of the urethra. Let's make sure he's okay. So, if we divide the anteroposterior thing in the prostatic fossa, we have upper one third, middle one third, and lower one third, or maybe anterior, middle, and posterior. So, the concept in Urolift is to create channel only in the anterior one third part. We are not going in the posterior two third for the sake that there are so many important neurovascular structures are there, and that's why our aim is to create an anterior one third channel.
Okay.
There are two ways to relieve the obstruction by means of keeping this implant. There is an immediate action and there is a delayed action. The immediate action is mechanical, as we see that whenever there is an occlusion of prostatic urethra because of the obstructing lobe, once we deploy the implants, it mechanically distracts the prostatic lobe. So there is opening up of the urethral channel. So this is the immediate mechanical impact which leads to improvement in the urinary flow and betterment in the bladder emptying. But and then this is the central one is the book picture, and this is what I could achieve in real world. This is the cystoscopic appearance of occluding prostatic lobes before the implantation, and this is after taking two implants, one at 3 o'clock and one at 9 o'clock. So make sure we are not doing anything at the bladder neck. So if there is a significant bladder neck hypertrophy or high riding bladder neck, we do not consider those patients for the Urolift because we are not traversing the bladder neck. Because if we do traverse the bladder neck, putting an implant across the bladder neck, it can lead to two things. Number one, it can lead to retrograde ejaculation. And number two, it can expose the other part of the implant to bladder urine and it can lead to encrustation. So mind very well, whenever you see a bladder neck hypertrophy, please do not use Urolift. So whatever bladder neck appearance is there, we are not going to change it. What we are changing is subsequent urethra between the bladder neck right up to the very minimum. And here you can appreciate there are two implants and it is very well opened up urethral channel, especially in the anterior one-third aspects. Secondly, there are people that are the questions creeping in our mind that whatever said and done, we do a mechanical retraction, but the prostate is a live organ and it keeps on growing. So there must be a question that if it grows subsequent to the implantation, what do we end up with? But I think there are enough histological data been done in animal studies, and what they found out was there happens to be a remodeling. So even if the prostate keeps growing, it follows the shape that has been created by both the implants, and that's why even at 2 years, 3 years, 4 years, 5 years, the delayed histological remodeling leads to persistent durability of symptom relief in the patients who have undergone Urolift. So this was all about the mechanism of action. These are classical indications. There are certain controversies, but usually we offer this to patients who are more than 50 years. But now there are decrease in the age because we are seeing this problem even in younger patients. So we have reduced this to 45 years. One needs to be bothersome. So one IPSS needs to be more than 12 to qualify that patient to be offered this Urolift. Max needs to be less than 15 ml second, but there are certain high flow, high pressure obstructive patients. There we can do this. If significant PVR is there, we are doing this now in certain patients who are on CIC. Even if they are having more than 350 ml PVR, what it does is decreases the frequency of the requirement of CIC. So even that is a bit controversial. And lastly is the prostatic volume. Usually we restrict this for gland which is moderate and large between 30 to 80 grams. There are certain centers we are doing up to 100 grams. I personally have restricted myself between 30 to 80 grams. And as the experience grows, we might take up larger glands. But as of now, 30 to 80 grams. And these are certain absolute contraindication for these procedures. If some patient has active UTI, we need to treat it first. If there is a urethral pathology which does not allow us to pass the 20 French sheath through which the implant goes, we can't do this. Even slightest suspicion is there for CA prostate, maybe in form of abnormal DRE or elevated PSA, we need to rule out presence or absence of carcinoma prostate by doing a preliminary biopsy, because in Urolift we don't get any tissue that can be sent for the histopathologic examination. So we need to rule out CA prostate at any stroke of suspicion. As I told you, prostatic volume more than 80 or 100 ml, patient is significant AUR. Now we are taking this patients as well. And patient with sizable median lobe, which is having significant intravesical extension and hypertrophic bladder neck, we are excluding this patient for the Urolift. Now let us, since this is a new kind of technique, this device needs to be looked at in detail. So this is generation 1 Urolift delivery system, which has got an already incorporated kind of implant. Now the generation 2 has this same as this generation 1, but they have a removable implant. So we can open this thing and we can just take the used implant, throw it away, and we can introduce a new implant and use the case same. So in a way, it is same like a GI stapler, wherein we can change the cartridge and we can use the same. The basic difference between generation 1 and generation 2 is to decrease the biomedical waste and be more kind of an environmental greener initiative. Otherwise, the overall mechanism is practically same. The first thing is this is a needle safety lock, and these are the implant which is having a scope lock. Here we are introducing the scope. The cystoscope which we are using in this particular setup is smaller and longer than the conventional cystoscope. What we are using is 4 cystoscope in our routine urological practice, but here we have to use 2.9 millimeter scope, and which is at least 4 centimeter longer than the conventional cystoscope, because this particular length of the implant takes up that extra space. And here we have a specific obturator which is designed for this implant to go in. So there are two differences. One is the smaller and slender cystoscope, and a specific obturator which can fit here and take this implant inside the bladder. After that, once we are there, we need to have three things. One is needle safety lock. this needle safety lock has got a lock and unlock position. So even unless until we unlock this, despite of pushing anything, we are not going to deliver any implant. So first of all, we need to push that and unlock it. Thereafter, this one is a needle trigger. The moment we press this, the needle will traverse from the urethral aspect of prostate across the prostate to the subcapsular part of the prostate. And then we press this retraction lever, which will deploy the prostatic component of the implant. I'll come to the detail about all the component in next few slides. But for now, these are the important steps of the implant. And lastly, we have a urethral end-piece release. So once we have done the needle trigger, needle retraction is there, we have deployed the prostatic part, then at the end we push this and that will release the urethral component. So there are three components. All these three components can be deployed in a sequential manner. I'll show you a small video. Just focus over there. So this is the safety. First thing we need to do this unlock. Then we have to deploy the needle. So the needle, which is 33 millimeter, which will be projected from urethra across the prostate outside the capsule of the prostate. And then we go for this urethral release button. Once we press this urethral component will be delivered over there. And there will be a suture connecting both the component. And once we release this urethral component will be deployed in the urethral part of the prostate. So here is the prostate. This is behind the capsule of the prostate. And that is how we do.
Can you repeat this video with buttons, if you don't mind?
Sure. I'll go again and do that for you. No problem.
Which button protrudes, button locks? That's a little.
I'll again do that. Give me a few moments. This video has it's not running again. So in short, this particular implant we need to see in detail. And there is, this company people, they provide a dummy implant also. So before actually firing the implant, when you are dealing with the case, before that you can practice as many times as possible. So they have a replica of that particular implant with us. So in that replica, everything is same, even the sound is same. So we can practice that in vitro when we are sitting in our consultation chamber or OT lounge, and we can do it multiple times to acquaint our mind which sequence we need to see. And
go to previous slide, it automatically starts. Go to previous slide.
No, there is a little bit of problem in this, so it will take some time. Anyway,
no problem. Even you can stop and restart is also.
Yeah, I'll restart. No worries. Yeah. Give me a moment. Yeah. So that replica is available. So once you start doing the procedure, the first thing is you need to equate your mind in that particular thing, and that replica can help you a lot. Train your mind which sequence we need to do this. So I'm again sharing my slides and going to the same slides.
So now cartridge has come. I mean, in entire white thing you need not buy.
No, you need to buy only this particular thing. That the generation 2 is having a complete case, and there is a disposable stapling device, same as GIA stapler. So now we need to buy only that particular case, and we can
you have to buy only cartridge.
Only cartridge, only cartridge, yeah. So that your biomedical waste becomes significantly less, because the whole thing, if you are using 4 implant, you have to throw this all 4 big chunk as a biomedical waste. So to decrease the biomedical waste, that is a basic difference, though it has not come into India and it is relatively costly affair than that. But it has come up and it will soon come to India, and we can do that. Yeah. So now let me again share my screen.
Yeah. Thank you.
Yeah. Sure. So I'll again go to that particular slide, and I'll show you once again. So can you see the slides now?
Yeah. Beautiful.
Yeah. So I'm starting the video. I can stop. So first thing is I'll just pause here.
Oh, don't stop.
Okay, fine. So this is the safety lock. The moment we do, now we are, see, now here I need to stop. So the moment you push, there are 2 different color of button. This is a blue one, this is gray one. So this is the retract. First thing is you have to release this locking to unlock fashion. Then you have to press this. The moment you press, the needle will come out. This device is in the prostatic urethra. And then this needle will traverse across the prostate for 33 millimeter beyond the prostatic capsule. So once the needle is gone, then you press both the button together. You see this?
Okay.
Both this button together. That will retract the needle, and that will deploy this
Yeah, yeah,
prosthetic
yeah, yeah,
component.
yeah, yeah,
In between, there is a suture. Now, this is a polypropylene suture. So
yeah.
once you release this particular button, that will lead to deployment of the entire implant. So this is the urethral part. This is the suture which has gone across the prostate, and this is the prosthetic component. So in
Correct,
between
correct.
these two components, the suture will hold prostate between this particular. And since the capsule is a tough one and prostate is bit tangible, automatically, logically, the prostate retracts towards the capsule and not the other way around. So what happens is a prostate which was like this can get converted into a bean shape. So there will be a midline kind of widening of that particular channel. I hope it is clear.
Correct, correct. Very good.
So next we see, now this is again in detail the implant. So we need to understand even the length, physics and mathematics here. So these are the three components. This is the urethral end piece, which is of stainless steel and 8 millimeter in length. And that is precisely why we need to be sure that we are not traversing the bladder neck. Because the moment we traverse the bladder neck, the stainless steel can get exposed to urine inside the bladder and lead to encrustation and a lot of problem. That's why we should never traverse the bladder neck. This is the capsular tab. This suture is holding both the component together. So this capsular tab is made up of nitinol. It is 13 millimeter, but if you take only the vertical length, this is 12 millimeter. And since this is 12 millimeter, that is precisely why whenever we start deploying the implant in the patient, we have to retract at least 15 millimeter or 1.5 centimeter from the bladder neck. Because if we remain within 12 millimeter, automatically this particular part will go in the bladder. So that is why we have to maintain a safe distance of 1.5 centimeter distal to the bladder neck for the first or the proximal most implant. And this is the polyethylene suture which can hold the tension. And the tension is the one which is all important to keep the prosthetic lobe away. And many patients had questioned that they, for a certain reason or other thing, they need to do MRI. So this implant is MRI compatible. There is no issue. And these implants are seen on an X-ray. So in first 2, 3 cases, we used to get an X-ray to see the way we see the back clips after radical prostatectomy. We see parallel kind of this thing in an X-ray KUB pelvic region. So we can be sure that these are in proper place. Now the whole procedure is, basically in 4 different stages. First thing is we need to do initial cystoscopy with that particular slender and extra long scope and dedicated obturator. And here the obturator has to have those markings, because if we don't have the marking, we cannot judge how much distance we need to remain away. Because the most relevant and most important thing is we have to retract our first set of implants at least 1.5 centimeter distal to the bladder neck. So that obturator has a marking. Even our obturator has markings, but because of repeated use, these markings at times disappear. But we need to be very sure that these markings are there. So that obturator is very, very important. Second thing, we need to ascertain the length. So that length is very important to understand and to foresee how many set of implants we might require. So for example, one set of implant on one side can take care of 1.5 centimeter of urethral length. So if certain, for example, a prosthetic urethral length of say about 1.5 to 2.5 centimeter, that can be taken care by only one pair of implant, one on right and one on left side. But if the prostate is bigger, the urethral length is longer, say about 4 or 5 centimeter, then automatically we'll have to have one more set of implants. So in total, 4 implants will be required. And that is why at times before conducting the actual urolift, there are recommendations to do an office-based cystoscopy to ascertain the actual urethral length so that we can counsel the patient how many implant will be required. Besides the urethral length, one more thing is the protrusion of the lobe. See, the lobe protrusion tells us the degree of compression which we need to apply while deploying the implant. I'll come back to that. So two things in cystoscopy. One thing is the prosthetic urethral length, and second thing is the prosthetic bulge and the volume of the prostate on cystoscopy. That two factors are very much relevant. I'll come back in the next few slides. Once again, I'm again re-emphasizing that we are not going to do anything in the posterior 2/3. Whatever we are doing is only in the anterior 1/3 compartment. And when we convert this into a kind of a wall clock, we need to be sure that in the entire clock, we need to play only between 3 o'clock to 9 o'clock. nothing from 3, 4, 5, 6, 7, 8, 9. So ideal position for implant is 3 or to 2 o'clock on the left side of the patient and 9 to 10 o'clock for the right lobe of the prostate. So we again re-emphasize, many a times people ask, what about the apical tissues and all that? But mind very well, these apical tissues, if we try to kind of, take an implant over here, we are going to injure this neurovascular bundle, and that will take away the entire advantage of this urolift. So there are modification of techniques there to treat the apical tissues, but that is beyond the scope of this particular presentation. I'll come back to it later. But as of now, for the beginners, we need to make sure whatever we are creating is an anterior channel from the veru to the bladder neck. This is the precise sequence. First of all, we need to treat the proximal prostate. And as I said, we have to be at least 1.5 centimeter away from the bladder neck. And this is a sequence. First, we do the proximal implant. Then, if the prostatic urethral length is longer one, then we set the veru and deploy the distalmost implant. And if at all is there is a bulge and there is a sufficient length in between, then only we can deploy this third set of implants. So proximal first, distal second, and if at all required, the middle component. So this is the standard sequence of events we need to follow whenever we are doing this deployment of that. And lastly, now we are able to treat even a certain degree of median lobe that will be taken as advanced technology. So we'll refrain from detailing on that. But yes, we can do certain kind of median lobe. They are not too big. They are not extended in the bladder too much for too much distance. We can take care of them. But this particular thing is sequence is very important. Proximal, distal, if required, the middle one. Now, this is the actual animation or animated form of the whole procedure, because we need to fragment this procedure into several things. So first of all, what we need to do is we need to put the device in the bladder, and whenever we want to deploy, this is mediolateral orientation of this the whole assembly, cystoscope, obturator, and the implant. So we have to turn it mediolaterally 3 to 9 o'clock, and then we have to retract that particular tip at least 1.5 centimeter distal to the bladder neck. And here, one more caution is we need to keep this bladder at least partially filled, because if we keep it completely empty, there can be some sagging of bladder wall here. Can you appreciate, Chandra? Here.
Yeah, definitely.
So,
Distension makes it away from it, and stretch, a
so
little bit of stretch.
Yeah, so we need to keep bladder partially full so there is no sagging of bladder happening at this level. So once we are sure that we are 1.5 centimeter and this orientation is mediolateral, it should not be anteroposterior. Then we need to compress. Now this compression is again depending upon the prostatic configuration. Now this can be 0 degree, 10 degree, 20 degree, 30 degree. So that depends on how big or how prominent the bulge of the prostate is. So if there is a medium bulge standard prostate size of 50 to 60 grams, we need to have 20-degree compression. So that how do we know how much degree compression we achieve? That is the angle between the vertical line and the lateral movement of this particular implant end on the surgeon's hand. So we are here, we are holding the implant in our hand. So we have to measure the angle between this vertical line and this. It has to be 20 degree. So moment we give this compression to 20 degree, that is enough for a moderate sized gland to deploy the needle outside the prostate. Mind again, the length of the needle is 33 millimeter. So it's a simple method, but except this gland was too big, then we need to apply little more pressure so that the needle can traverse the entire distance. Initially, we used to get the truss guidance, but that was becoming a bit clumsy, but that can be done. So subsequent again, the sequence is same. We can unlock the safety. We can push the blue button that will deploy the needle. Then we can push both the things together. So needle will get retracted and the prostatic component is deployed. And then we can reduce the pressure a little bit. And then we can have forward movement so that there will be tension in the suture line. And lastly, which is called as a white line maneuver. I'll come back to that maneuver in the next slide. And then we make this urethral release button. So once we do that, the scope will be free. This will be the urethral plate. This will be the prostatic component. In between, there will be suture. And our assembly will be free. And we can take it inside the bladder and then convert it from mediolateral to anteroposterior direction, because the tip is quite rough. So whenever we are taking it out from the urethra, we need to have this anteroposterior orientation. So these are the sequences of all the steps in one by one, so we can understand it. Now I'll have a little bit of detailing about the compression. Now, see, now this trajectory of needle is not transverse. Trajectory of needle is forward. So even if you are keeping at this particular 1.5 millimeter away, this is the blue line is bladder neck, and we have kept it 1.5 millimeter away. Still, because of the forward trajectory, this needle goes forward. So if you don't keep bladder full, the bladder can be sagging here, and this can traverse the bladder. That's why we need to keep the bladder full partially, so that it can remain away from the prostate. So if there is no compression, this needle will go forward for 12 millimeter. If there is 10 degree of compression, then this distance will be 7 millimeter. If 20 degree, it will be practically transverse, only 1 millimeter. And this is the most common degree of angle, the most common compression which we are applying, so that, wherever we are, we expect that at the same level, the prostatic component will be deployed. So that's why this 20 degree compression is extremely relevant. And if there is a large prostate, we can still increase the level up to the 40 degree. And in that particular scenario, the needle will actually not be transferred, it will be distally as compared to the tip of the device. Are you getting this? So this is
That's right.
all about
Slide.
compression and
This
degree.
is
So we need to
very,
understand
very useful
mathematics.
slide.
Yeah, so we have to understand the physics and the mathematics very clearly. Nothing great in the technique, but these are the things we need to understand in our mind. I'll show you as once again in the actual series. See, now we are having 1.5 centimeter away, and here we have given 20 degree compression. So practically it will be transverse. If you have not given compression at all, see, the needle is going forward. And then when you move towards that, even if you have 1.5 centimeter away, when you move further to deploy the urethra, there is a risk of urethral component to be deployed at bladder neck level. So that's why two measurements, 1.5 centimeter away from the bladder neck and a 20 degree of compression. So these two things are extremely relevant to avoid traversing the bladder neck. So please again focus on this. And these are certain maneuver which will help getting complication in first few cases. And this white line maneuver, this is actually to see our suture. So whenever we first deploy the needle, there will be blue thing. So I'll have a small video. I'll again elaborate that thing, but kindly focus here. This is the blue thing. Now, once we deploy the needle, this blue line will appear. And then once we move it forward, this is the white line. This is the white line. So that white line means that the tension is adequate. So ideally speaking, whenever this white line occupies at least 50% of this particular hall against the backdrop of blue, that is the point when you should release the urethral release button and cut the suture to have appropriate tension. So this is called as white line maneuver. It's extremely relevant. And that is why even during the cystoscopy, you have to focus your camera and scope such a way that you are not seeing this mucosa. You are seeing this particular blue keyhole. So even that focusing needs to be very precise right on that. So this is that particular window. So we don't need to see the bladder or prostate. We need to see this particular. So our focus should also be like this. This may go hazy, but our focus should be here because white line appears here. And once the white line occupies at least 50% of this hole, that is the time when we have to push the release button. So this is a small video again. This is, lateral lobe. I'm dealing with the lateral lobe. So right now I am dealing with the left lobe of the patient. So I've been in the bladder neck, retracted myself for 1.5 centimeter. And then I'm giving 20 degree compression. Can you appreciate here?
Yeah.
Yeah. So we are giving 20 degrees. We are moving from midline to 20 degree. And once we are settled down there, I push this with my index finger. So the needle goes. Then I compress both the things together. So there will be implant delivered, that's prosthetic component. And then we have to keep forward going and, keep on seeing here, keep on seeing here. See, now we can see this white line.
Yeah.
Yeah. The moment you see that white line, that is when you again cut it and again come back in the 0 degree position, and you can advance your implant delivery into the bladder. So this white line is very, very relevant. I can again show you this thing. So first of all, we retract at least for 1.5 centimeter
What
away
happened?
from.
A brown line is coming on transmission exactly at that level.
Yeah.
You can minimize and show brown line because
Hmm.
of the it's seen. Okay, you carry
Yeah.
on. Just below that brown line is no problem. You carry on. Now you are pressing.
Yeah.
Yeah. Now white
Moving forward. Yeah. Now see,
moving
now
forward.
I'm just moving forward. So I'm going towards bladder neck. Now you keep focus here.
Yeah, yeah,
Yeah. Now it is enlarged. Now you see here. Now you see this line. Yeah.
yeah. Okay.
So that is the line. Once you see that line, you cut it and then the implant is
Your
deployed
scope
and you
will
are,
be behind. Your scope will be behind this. Is it 0
yes.
degree or 30 degree?
No, this is a 0 degree scope because we
Okay.
are intending to see what is in front of us.
Yeah, yeah. Okay. Right.
So this is how we deploy the lateral lobe. And we have seen that. And this is small animated shot of the whole thing. So this is animated version. We do the initial cystoscopy and assess both the things, the bladder neck, the length of the prostatic urethra, and how kind of bulge of the prostate. And then we start with the right or left lobe depending on your convenience. Whenever we are dealing with the right lobe, you need to hold the entire assembly in your left hand, and same vice versa. Whenever you're dealing with the left lobe, you need to hold the delivery system in your right hand. So here, same thing. We'll deploy the prosthetic component, and then we run this tension, seeing that white line, cut it, and then we direct this particular device in the midline to go here. So that is the first set of implant, which is 1.1 centimeter length. It is putting the distal part of the right lobe. Same thing now we are doing same maneuver. First you unlock, then you deploy the needle, then you retract the needle, push both the button together, deploy the prosthetic component, white line maneuver, cut this suture, deploy the urethra. Same thing here. So now first is the distal set of implant. Now see, this is that particular suture. By the forward movement, when we cut it, that is the time the implant, the urethral component of implant will get deployed. So this is how we cut the suture and the entire assembly. First we deal with the distal aspect, then we come towards the treat the most distal aspect of the prostate, and then if at all in between, if you see there is a significant bulge or obstruction, we can deploy the third set of implant. But by and large, you the proper selection of both the set of implants. With more implants, you can go over with the lens size of 60 to 70 years. So this is actually the preoperative appearance in the prostate. So this is the immediate mechanical impact what it creates. And even if you do a Credis maneuver and
Want
see
to
the urine
understand
flow, you can notice a very reasonable amount of improvement in the flow.
this
Now let
cutting
us
of
see the
the
actual thing. I hope you can see the video, Chandra.
yeah, yeah. One point before you play.
Hello,
One question before you play.
are you there, Chandra?
Yes, yes. One question before you play. Hello. Are you listening?
Rajender?
Yes.
So this is standard cystoscopy. We are having a look at the both the urethral orifices. We are seeing this bladder neck not being too tight, and this is grade 1 enlargement of prostate. So what we do is we are here with the implant delivery system, and this particular is the Holzkörper, which is there. So now we are turning it mediolaterally, and we are going anteriorly from the anterior apical commissure, and then we have settled down at 3 o'clock. This is the initial call then. I don't see the response.
Hello.
So this is delivering the needle, and then now doing the forward movement, and you just keep focus over here. We can see this white line. The moment we see white line, we cut it, and then we shift to the midline, and then we go. Same thing again on the right side of the prostate. Same maneuver, shifting this apical tissue a bit on that side so that to create
Ask him
even a posterior
ask him
channel.
to increase
At
the
9
voice.
o'clock,
Switch
we are
off the
firing the
voice.
needle
Volume.
and then deploying the prostatic heart, and then
Volume of
going
his
forward.
computer volume.
Yeah. And here we are going. So
Hello?
both the set of implants are gone, and this is the appearance which we get at the end of the procedure. So see, this is very clear. Whatever anterior channel we intended to clear,
Yes.
has been done. So here I'll again show the implant. We just come back from the prostate, and this is the right implant. You can see
Hello.
this, and here is the left implant. And in between these two, we could create a very good channel. And this is the intraoperative Cadis maneuver, and rough kind of judgment of whatever urine flow we are expecting, and reasonable amount of flow is there. So this is what we get at the end of the implant. Chandra, are you there? Hello.
Hello. Can you hear me? Can you hear me?
I'm not responding on this. Ask Chandra Mohan to.
You increase the volume. Something. Hello. Are you able to listen to me? No. I can listen. I can listen what you are talking.
I cannot hear your voice.
Something has happened after you started that video.
Just video start. Just video start करो वैसे मैं raising features
Like, volume होता है. Probably might have
Yes.
reduced that.
Yes.
Can you hear me now?
No, you can hear me. I am listening. Everybody is listening. Only I was asking one question.
Yeah, please.
When you have deployed, you moved the scope to cut the thread. Is it you have to move it?
Yeah, we have to move from distal to the proximal. So if we
How
start,
much we have to move? Is it before the button pressed or last button pressed, or the how to do that?
I'll show. I'll stop share and I'll show you. See, we are at the bladder neck. We retract
Yes.
our 1.5 centimeter.
Yes, that
That is where
understood.
we deploy the prosthetic component, and then we stay, and then we move forward toward the bladder neck. So
Okay.
once we move forward, the suture which was initially transverse, now it will go oblique.
Okay.
Correct. Oblique. So we go forward. At the moment we see that white line, that white line, it signifies that enough amount of tension is created. So the moment we see the white line, that is when we press the urethral release.
Last
So
button.
once
Yes.
last, so we at least have to traverse 8 millimeter or 10 millimeter distance from the initial site of deployment of the needle.
That is the
So
one which applies traction.
yes. So once we reach that 8 millimeter, 10 millimeter, and then we urethral release button is pressed, the suture is cut. So the urethral component with the suture connecting to the prosthetic component will be deployed as a total one component.
Okay.
So that is what the movement we need to see. Again, sharing this the slides. Now, so can you see Chandra here? Yeah.
Yes.
Yeah, so these are the whatever said and done technically or technologically or visually anything which can appeal us, but we need to see whether this has got support of the literature. So these are initial lift studies. Subsequently, there were crossover studies done by Rauburn and Cantwell, and this is a local study. All these studies been done in last decade. They all have confirmed that this procedure could be done in local anesthesia. Having said that, Indian patient being little more sensitive, I personally feel we always do it in pseudoanalgesia, a short kind of 10 minutes of anesthesia using IV sedation. That makes their life very easy. The patient can get back to their normal activities very fast, and there is a sizable improvement in IPSS score. These are the initial studies. All the studies have been done in early part of the 2012 and 2016. But now we have several more literature which is proven that even at 5 years the increase improvement in the IPSS score is sustained. So that durability which was initially questioned, this particular trial has answered to that, and they say that whatever improvement was achieved initially, it sustained till the point of 2 to 5 years. So overall result, if we can speak in nutshell, there is a significant improvement happening in IPSS as well as QMAX. But more relevant and important is there is no incidence of any de novo erectile or ejaculatory dysfunction. There is no de novo incontinence. And overall, the quality of recovery is very, very fast. Like yesterday, I happened to do a case who flew from Mumbai. He was from USA and he was planning to go to USA, and he chose us over that. And then he flew on Monday, and we did the Eurolift on Tuesday, and next day morning he took flight back to Mumbai. And when he was dressed up in his executive dress, it was really difficult for me to see that he was the same patient who I happened to do a Eurolift 20 years ago. So that the quality of recovery is very, very fast, but it's not free of complication. There are complications to tune of 3.4%. Most of them are quite minor. The most common being urinary retention, which actually happens in those catheterized patients. The catheterized patient at times need 3 or 5 of catheter time. So initially, this Eurolift was not supposed to be offered to the AUR patients, but now we are offering this Eurolift to even these AUR patients. But one thing is that catheter-free time in non-catheterized patient as compared to the catheterized patient is more in the patient who were on peripheral catheter. So there is no harm in keeping catheter for 3 to 5 days. In our practice, whenever we deal with a patient who has never been catheterized, we just don't leave a catheter and make patient void after say about 2 to 3 hours. Initial little bit of hematuria, dysuria is there, but if you do a thorough counseling, by the end of the day, they are all good to go, and we can avoid putting a catheter. But those patients who are already on the catheter, they do require keeping the catheter at least for 2 to 5 days. So there is enough amount of literature starting from 2011 to 2019, and even now there are so many articles coming in last 2 3 years. I have selected a few articles from different corners of the world. This is a Canadian study which was published in Turkish Journal of Urology. This was again, a very landmark study, which I'm going to elaborate in detail because this BPH6 study, it's a revolutionary study for us as a urologist to understand BPH. There are studies from the Europe, there are studies from the USA with real evidence, and all these studies have substantially confirmed that the outcomes of Eurolift as compared to the TURP or HOLEP are better, especially when we take the improvement or worsening of the ejaculatory function and erectile function is concerned. And there is equivalent improvement in the IPSS score, though the fossa which you and I see at the end of enucleation, we cannot match that particular result when we do Eurolift. So that is one training which we need to give our minds that we cannot have that bigger fossa, and we don't get 35 ml per kind of second of Qmax. But that is not we aim for, and that is why I would like to focus on this landmark study. Kindly go through this article. It's a wonderful article. It was conducted in 10 European centers in 3 countries, and it was actually called as BPH6 study because they had used 6 particular components as a validated instrument to assess patients' overall health, not just the urination part. And they followed their patients the 2 weeks, 1, 3, 6, 12, and 24 months. And these were the 6 components which were very, very important in this BPH6 study. So LUTS was only one of those 6 components. Adding to that, there were erectile function, ejaculatory function, incontinence, quality of recovery, and de novo complication. And all of them were scientifically assessing all these international the acclaimed scores. And TURP scored over Eurolift only when it was concerned with the LUTS. And I said earlier, we cannot get the same fossa at the end of Eurolift as we get in after TURP or HOLEP. And we don't get that matching Euroflow, huge spike. But when we take this out of consideration, if we talk about erectile function, ejaculatory function, and incontinence, recovery of the quality and complication, Eurolift did significantly fare better than TURP in their cohorts. And that's why even in the AUA BPH guideline, Eurolift has enjoyed as a kind of a treatment option for patients with LUTS secondary to BPH when the gland size is 30 to 80 cc and there is an absence of obstructive median lobe and there is a moderate recommendation grade C. So need to be selective in offering this patient this particular therapeutic option to few group of patients. And even in our USI guidelines, we have incorporated this Eurolift. I won't go into much detail. So basically, these are the advantages. No catheter in most of the patients can be done under local or pseudoanalgesia. Hardly a need of hospitalization. It can be a daycare event. No incontinence. Ejaculation is very well preserved. Erectile function is same as what it was before. And the quality of recovery was excellent. Patient can go home same evening, get back to his work next day. But there are a few concerns that the improvement in LUTS, if we focus only as LUTS in patients with BPH, the improvement as compared to TURP or enucleation is definitely lesser. There is no debate on that. Second thing, the long-term data, not very much validated, but now we are getting 7 or 8 years of follow-up. So now we are getting those results, but still it is 1 or 2 year away from 10-year data. The retreatment rate is quite high. So at 5 years, there is documented 13.6% retreatment rate. If we talk about TURP, the need of retreatment at 5 years is 5 to 7%. So that's significantly high, but it doesn't, the patient is not devoid of getting one more set of Urolift or TURP or HOLEP if he requires a second treatment at 5 years. He still can go with HOLEP. It doesn't preclude doing a Urolift, doing an implant does not remove a possibility of the patient undergoing TURP at later stage. So this 13.6% retreatment rate needs to be impressed upon the patient. Cost is a huge constraint. So that these are the concerns. What I feel in my practice, you also might be feeling the same concerns. So my take-home message, Chandra, would be it is the most physiological way to treat BPH. It is not, and it is never a substitute for laser or TURP. Selection of treatment is of utmost importance. We need to be very, very stringent to offer the treatment to get the optimum outcome. It can be offered to patients with moderate enlargement of prostate, 30 to 80 grams. UTI prostate cancer needs to be taken out of context if you are planning this Urolift. It is free from bothersome side effects of BPH medication. We have several patients who get, so much of bothersomeness because of giddiness, headache, or retrograde ejaculation. This is absolutely free of that. It is more patient friendly as compared to the TURP laser. The downtime is very less. They can get back to their routine in no time. So ideally, who are the candidates who you or I or anybody can employ this Urolift? Relatively younger patients who are sexually very active. It can be offered as an alternative to patients who are settled down on medications, but they are having issues either with the compliance or with the side effects. It can be offered in very high risk patients. The patients who are having ejection fraction of say about 20-25%, or somebody who is having CKD, somebody who is having liver disease and bleeding issues. These patients ideally are qualified for this particular procedure. And there are patients who are not willing to undergo surgery because of the potential side effect and complication which they foresee. So these are the 4 group of patients wherein I personally feel there is an indication to offer Urolift as an option, not as an kind of replacement to TURP or laser. So these are my particular indication for Urolift. I think that's all for now. And I really thank you again, Chandra, and the whole attendees for this patient listening. I'm here to answer all your questions. Thank you once again, Chandra.
Thank you. Lot of audience as it's a new thing. 150 audience were there. In the recent past, it was turning around 60 to 70 audience at the moment. By tomorrow, I think it will reach 1,000. It is a permanent document, and this YouTube link will be there always. Very, very extensive information, complete as of today. Now, let me ask question. In fact, you are appreciated by few. Sachi Shankla, very in-depth lecture it is. Thank you very much. So, first question is, if gland is long length versus vertically thick, one I am asking long length gland. Another is anteroposterior depth. Two is there when gland size. Which one, if it is more, in your logic, this is slightly less functional?
See, whenever there is anteroposterior kind of length is more, that is, these are the group of patients who will not significantly benefit because of this. Because even if the urethral length is 4 centimeters, 6 centimeters, you can deploy sequentially one of implant, second, third, even fourth. So I have maximum I have put in was 3 pairs of implant. But when there is anteroposterior, what your contention is, you can do only in the anterior 1/3. But now we're coming with some innovations. So even the apical tissue, there are questions that apical tissue can never be treated with this. But now we are doing with a sweeping motion. There is a specific device coming up where we can sweep the apical tissue from posterior to anterior aspect, and we can tag that at 3 o'clock position. But as of now, the anteroposterior dimension is more. Urolift is going to be less significantly improving. Yeah.
Very good. Second question from Anil Mani. Can it be done when you are on anticoagulants? That means aspirin and clopidogrel, not exactly heparin. Aspirin and this will be the common future because enucleation has survived for a long with aspirin 75. If Urolift survives with aspirin 150 and clopidogrel also, yes, it's after listening to you, I'm feeling that when company people are asking so many times, I was not listening. When you have done it, I was not very keen because I had case other theater. Now calmly
Right.
I'm listening. Yes, you are just separating with your finger both sides and opening a little bit. As simple as it. Of course, cost is the concern. So question is anticoagulants.
Yeah. Theoretically speaking, the only problem I have done 3 or 4 cases keeping patients on blood thinner. There was not a problem. But in the early kind of experience, I would recommend not to keep this anticoagulant on. The reason being, if your orientation to compression is not proper, and if you do little more compression, there is a tendency that this needle will penetrate something important in the pelvic cavity. And there are incidents, very sporadic, but there are like incidences of pelvic hematoma
Yeah.
after urology. So if your compression, you are not very much oriented with the degree of compression. If you are too less or too more in compression, that can lead this kind of disastrous complication. So at least in first few cases, it is safe enough not to keep patients on and hold it for at least 48 to 72 hours.
What is the chance of hematoma anywhere in the tract by Dr. Ramakrishna?
Tract, see, the
Hematoma
hematoma occurs in a cavity. So it never happens in the
in
I have
between.
done whatever cases. So either the hematoma can happen or blood clot can happen in the bladder, or it can have an pelvic hematoma. These are the two kind of, bleeding complication can occur. So bladder clot happens when, there are, if you're piercing. One more thing is the tip of that delivery device is very rough. So that's why we have to rotate it before taking it into the fossa. So if you're taking it like that and you're maneuvering too much, there can be abrasions of
The
prostatic
mucosa.
surface. So then, this
Then
patient,
goes.
if you're not put a catheter, they can have some bleeding and they can turn up with bladder clot. But you can anticipate this thing. Second thing is pelvic hematoma. In world over literature, I think I have come across 2 or 3 such cases which ended up pelvic hematoma. So it's not very common. But yes, theoretically, it can happen.
What about another question from Anil Mani? Chances of implant failure if you don't do well.
Yeah. Yeah, implant failure is now two kind of. Number one is immediate failure and number one is delayed failure. Now, delayed failure occurs for different reasons, but immediate failure is whenever you are doing compression, if you are compressing it too much, next to the prostate is pubic bone. So if you are compressing, say about 30, 40 degree, and you have to keep your hand very, 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 very loose. It's like a swimming. So if you keep very tight and very spasm, the compression is too much. The needle, which is 33 millimeter, understand? The pelvic bone is next to the prostate. So if you're compressing too much, this bone will come in that 33 millimeter window. So what happens is your needle, tuck, say you press, the needle hits the bone and comes back.
Okay.
It hits the bone and comes back. So that's the implant failure. Hold on, I have got an implant to show you.
Nice. He has gone into the depth.
See, can you see this implant here?
Yeah.
So this is the needle. So this is the whole implant, and this particular is the needle. You see.
The
So
sharp.
this this is a sharp needle. So this is a very sharp end. I have kept it with me because in one case, what happened was the patient's prostate was small, and the compression which should be, so this is the normal thing. Compression was too much. So when I fired it, the needle end, this particular end, hit the pubic bone and it came back. So this is the implant failure. So if you compress too much, this 33 millimeter will be hitting the bone and come back. So this becomes absolutely blunt now. So this particular end is absolutely blunt because it has hit the bone and come back. So this is the implant failure.
If you don't press, the effect will be lesser.
Absolutely. So we have to understand the mathematics and physics that, we have 33 millimeter to traverse. If there is an 80-gram gland, you have to give 30 degree, 40 degree compression, then only it will go beyond the capsule.
I think
Otherwise, if you don't compress.
good trust before surgery can help.
Yes.
Not
yes,
during the
good
surgery.
Truss,
Not during the surgery.
Absolutely. Initially, people used to do MRI, but I found having a truss in the initial first cases gave me a lot of. It's same like prostatic biopsy.
Yeah.
In a logical
Opposite
way.
direction.
Absolutely. But only thing is that here you cannot adjust the needle because needle goes in one shot. So the moment you press, needle is gone.
I
So
think
whatever
future,
when
like
you
in transplants, knee joint transplants, different lengths also can come. We don't know.
that's what we are now coming up with, that we have to select different implants. So in the generation 2, where there are only cartridge available, there we are planning that, depending on the prosthetic configuration, which we have X, double
Right?
X, triple X, this
Yeah.
kind of, categorization.
Yes, yes. Fantastic.
So
Fantastic.
that is what going to come up in next few years. Yes.
Uh, mm, so Mohammad Ibrahim has asked, does it have side effects like retrograde and impotence for productive patients? As you said, no, no, no. It is the biggest
It
advantage.
happens. It happens the moment you traverse the XE. That is one more modification we are innovating. We are in touch with the R&D research and development team, and I have been invited to them, and I have got something in mind which they want to use in the new generation implant. That the bladder neck is very, very important. So if you by chance see measure 1.5 centimeter is very critical, but that depends on how much stringent you are for the marking. So accidentally, if you just retracted 1 centimeter, you start firing and then you go in. If you traverse the bladder neck will remain completely open. So it will not close at the time of intercourse, and that can lead to retrograde ejaculation. So a malpositioned implant will lead to retrograde ejaculation.
So
A
better do
well-positioned
error
implant
half
will not.
centimeter inside the bladder neck.
More.
More.
Yep.
More
Yeah.
distal. More distal.
More distal, yeah, more away from bladder neck, and that's
Correct.
what we are doing now. Right now, if you see, the implant mechanism is forward going. So we come 1.5 centimeter, we select a place, fire the implant, and we go towards bladder neck. Now we never know if by chance we have moved 5-6 millimeter here, we might traverse the bladder neck. So what research I am doing is I'm trying to backload it. So we just stay at the bladder neck, recede a bit, start firing, and then we have distal movement rather than proximal movement. So that is the research which I'm doing, and I'm really hopeful that we can come up with something very, very realistic, logical, and Euro friendly.
Yes. Next. These are the questions. I will ask my questions. If you are, for example, if you will you give anytime anesthesia in this or not?
All my patients, I have done a couple of patients in local anesthesia, same as in prosthetic biopsy, but there are patients who are not very well, they are not
If
signs
by
of
giving
movement during.
anesthesia, can we do the job better? Simple question. Spinal anesthesia, if you give, I don't mind, but still patient wants to go on the same day, they can go. If I
Yep.
give spinal, can I do it better without any technical failure because patient movement ये सब नहीं रहेगा ना?
Only thing is the position in this patient is high lithotomy. So if you are comparing local anesthesia or no anesthesia with anesthesia in any form, analgesia or spinal anesthesia, on any day, anesthetized patients will be better because the position you can give it more properly. There will be no untoward movement when you are firing, because when you fire, there will be a pinprick sensation and then can lead to change. So on any day, giving anesthesia will save your day.
You are very honest. Very nice. Excellent.
Yeah.
That is
So
very
let us not market that in. We have to be very realistic, and we have to be. See, I have seen couple of videos of the urolith from the Western population, and I could see the patients. They give them Google Glass, they give them speakers, they give them to watch the movie. We don't get those kind of patients.
Yeah.
They're not interested in watching those movies.
Even
So
in
we have to
prostate
have that
biopsy,
clear.
if you don't give local anesthesia, there will be a prick sensation will be there to them.
Yeah.
Even though we are beyond the anal verge. Anyway, the second question is this the urethral side needle which is present after 1 year, if you go and see inside, do you think that it will get buried with the mucosa?
I have done a scopy. What we see only the tenting. The angulation is there. Initially, when we are showing the video, we can see that urethral end piece, but gradually it gets epithelialized. And after, say about 3, 6, 9 months, if you do a scopy, what you see is that indentation, but you don't see that urethral plate. But I have done one job to cut, so I did an enucleation. It was as simple as a normal enucleation for a patient who came
During
from.
enucleation, do you think that this needle can be marcelated, or what can be done?
See, that was I was actually worried when I did enucleation, but the enucleation went very well. In the enucleation, I could never actually understand that something is different than the normal enucleation, and even the morcellation, it turned out nice. I was actually trying for that if at all I can find that piece, but I could not, honestly.
Not possible, probably. Very
Yeah.
nice. Very nice. In the worst that can happen is it doesn't function well in LUTS. So you can choose the later option if you tell the patient. It is not a morbid or mortality type of procedure anyway.
That's what the Western population call this as a bridge procedure. It's a
Bridge.
bridge. Like, for example, a patient who is right now 50 years, his concerns are both sexual as well as urinary.
Yeah, yeah.
Right. And so we can give him a quality of life the next 5-6 years. He can have moderate urinary symptom improvement and a good sex life. It's fine. At the end of 6-7 years, if he falls at 13.6%, he can very well go ahead and end up getting his TURP or HOLEP done. So they call it as a bridge therapy. So that
Common
concept
question.
is there.
One
Yeah.
common question. Naturally, it is difficult for you to answer. A lot of people ask me also, what is the cost of laser, how it can. The only thing what I ask is, if you want to, in Indian scenario, if you want to implant two, in a two settings, I am asking, corporate versus private hospital, your own hospital, two implants, only two, one on either side. On an average, I don't want to go into the details. On an average, with your profit, average profit,
I understand.
how much you can charge and get away?
See, normally, let me tell you, the implant
range
cost.
At least.
I'm absolutely honest. I have nothing to hide. No conflict of interest. No kind of things. The implant cost is 1,05,000 per implant. If you're doing two implants, you actually end up paying only 2,10,000. They have done something for us, so that can be talked in person. But they definitely. But right now the cost implant as per the their bill is 1,05,000. So if you are talking about two implants, 2,10,000 plus you add your operative charge and whatsoever, and you can get away doing that surgery in 3.5 lakhs rupees.
Yeah, that
If
is
you're
the
doing four, we can.
probably in the Indian scenario now, in tier 2, tier 3 cities. In a corporate setup, yes, it is acceptable. I don't know whether insurance is accepting this or not.
Yesterday's case was now out of 20 odd cases we did. I have 7 or 8 cases we have done under cashless thing. Cashless, not even insurance. Yesterday's patient paid us 5.5 lakh rupees, and then because they're dicey, they were not sure about insurance, but then insurance company settled the thing, and we had refunded them. So it was sanctioned in the cashless, no problem, sir.
Great. So that means it is picking up. On another end, I am little happy that we are progressing towards research. Change is inevitable. This may change. And last two questions: injecting regime, steam versus this. Steam injecting is nothing like a HIFU or anything which coagulates necrosis and reducing volume by killing the cells. Here it is reducing volume by pressure reducing, by separating them. So if they come for both cost, if they can do both under local anesthesia, what's your gut feeling that which one will go forward in the coming 10 years? We will discuss. Pure will be there after 10 years also.
Maybe.
Then I will ask you the same question by the time
I am recently, the resume is going to be, I'm going to be having the hands-on experience on that. But as far as I have no experience personally, neither of us in India. But as far as the literature is there, the only problem with resume is too much of dysuria. And that is precisely you said, because of that all, heat and all that destruction of cellular destruction. The post-coronary frequency RNC dysuria is prolonged. So that is a big problem with the resume, which is not seen in that particular segment in Urolift. And I personally see whenever resume.
What is the mini HOLEP? Nowadays,
Mini HOLEP, see, I am doing it for quite some time now. There are two stages of mini HOLEP. The conventional HOLEP, which we were doing with 26 French assembly. Then we used to do it with 22 French assembly. But still, for the morpholation, we had to use the 26 French. That is stage 1. That is mini HOLEP. And what I am doing is micro mini HOLEP, wherein I am doing this 22 French inclination.
HOLEP is same, but is the instrument which decides?
Yeah. So let's say, at 60 minutes of HOLEP. Just think about mathematically 60 minutes of HOLEP with 26 French. Your urethra tolerating 26 French instrument for 60 minutes. Stage 1 mini HOLEP, you're doing enucleation 40 minutes part with 20.
What is the company which is very good for 19 French as of now? No conflicts of interest, because a lot of audience are online. They will be hugely benefited. Even the PGs, they have to write all these. so they will get benefited forever. So what
I'll
are
tell
the
you.
sizes you have with your knowledge?
So I'll just tell you that mechanical is 60 minutes with 26 French. Second stage is mini hole where 40 minutes enucleation you can do with 22 French assembly. I have that Shawly, even stores have same kind of thing. So I'm happy with both the thing. Then 40 minutes, after 40 minutes, you have to change over to 26 French because we never had that small morcelloscope. So we had to change, and that next 20 minutes or 10 minutes of morcellation, urethra had to tolerate 26 French. Now came is RNZ. There is a company called RZ. Now they have come up with a morcelloscope which goes through 22 French assembly, and from which morcelloscope even the luminous blades and the current BioRed blades of morcellate is going. So now today I did 2 HOLEP, both the HOLEP, micro mini HOLEP, where entire 60 minute is 22 French. So even enucleation is done by 22
That
French.
is only possible with EZ and BioRad. Both should have.
Both, see that RZ morcelloscope goes in the 22 French. So the good thing is, even you do 22 French assembly enucleation, if you do not have RZ scope, you take out the entire thing. The moment you take out the entire thing, there is a collapse of prostate, lot of bleeding. Again, you have to introduce 26 French. Now with RZ scope and Shawly's 22 French assembly, we can keep the outer sheath inside, take out the inner sheath working element scope out, and introduce the RZ morcelloscope. And from that RZ morcelloscope, luminous blade as well as BioRed blades can go, and you can finish the entire thing using only and only.
That may be costing around 10 to 12 lakhs total. I feel
it is very costly. I think the morcelloscope is pretty expensive. I still don't have exact figure, but I'll check. But I think it is costly affair. Yeah, but that is the actual mini hole, to be very precise. So whenever you come out 22 French, when you finish the things and you come out, you hardly see anything into the urethra. So
I have
urethral stricture incidence.
I have tried a small gland with 15 French nephroscope Wolf. It can be doable, but the laser fiber ovules, because of the lumen size, laser fiber ovules, and you cannot control whatever initially. If something introducer comes into the Wolf, because it is rotatable, Wolf 15 French is rotatable. If the lumen can be controlled, if the laser fiber is fixed, you can rotate and remove small glands, and later on bigger size can be. The problem with is everybody is having 26 morcelloscope. That is the Indian urethra. That is the thing.
The game changer is small morcelloscope from RZ company. That is actually
should be available for low cost in Indian setup. Then it will really change the scene of the.
We are doing something with that. We are planning to come with a digital kind of morcelloscope. Allow us some.
Kaushik Shah ko bhi bolte ek baar. You can tell to Kaushik Shah also.
Yes, he has done one. I have demoed it once. There are a few glitches, so we are working. We are fine tuning with that. I think 2024 will see a light.
Great. And you wanted to mention last comment, any other minimally invasive surgery treatment for theory sake? One, we talk about the mini, ultra mini, the enucleation. Second is regem. Third is Urolift. Any other thing just for the sake of theory? No, not
personally. Much. No. Personally, I restrict myself to enucleation and this mechanical separation. That is Urolift. Resume, I'm having planning to get hands-on in coming months. So I'll have some experience. I'll come back to you.
Okay. Thank you very much, and excellent talk. Highly appreciated. You have really got hand on this subject. This is the way changes happen. This is the way things happen, and the practice changes also happen. I really appreciate. Thank you very much.